Hey everyone, welcome to my YouTube channel, Just Another Medic. My name is Kuljan Jandu, and in this video we'll be talking about diabetic ketoacidosis and hyperosmolar hyperglycemic state, otherwise known as DKA versus HHS. We'll start by comparing the two conditions, looking at the symptoms that these conditions present with, and how you manage both of these conditions. DKA occurs in type 1 diabetics, whereas HHS occurs in type 2 diabetics, so it's important that you understand the basic physiology of type 1 and type 2 diabetes. If you haven't done so already, please check out my video on type 1 versus type 2 diabetes. If you haven't watched that video, let's just give you a basic run through of type 1 and type 2 diabetes. Type 1 diabetes is where your beta cells in your pancreas are completely destroyed and so no insulin is produced. As the insulin is not produced, the glucose that's within your blood is not entering your cells, and so your body switches to a different type of metabolism called ketone metabolism, allowing DKA to occur. In type 2 diabetes, your pancreas still produces the insulin, however, the cells in your body have developed resistance to that insulin. And because that insulin is still being produced by the pancreas, there's no switch to ketone metabolism in HHS, which you do get in DKA. Symptoms of DKA present very quickly, however, HHS has a more gradual progression. So when taking history from a HHS patient, they could be presenting with symptoms that have been going on for days, whereas in DKA, they could be a matter of hours. And because these HHS patients are presenting very late, upon presentation, their glucose levels are much higher than DKA patients. In HHS, the patient's glucose levels could be above 600, whereas in DKA, it could be above 250. And because of this hyperglycemic state in HHS, the osmolarity is also higher than DKA. Osmolarity levels in HHS could be above 350, and in DKA, it could be between 300 and 320. Bicarbonate levels in DKA are usually below 15, and in HHS above 15. An anion gap is also found within DKA, as well as ketones, which are usually absent in HHS. The symptoms of diabetic ketoacidosis are fairly similar to diabetes itself. These include polyuria, polydipsia, anorexia, and lethargy. Apart from that, patients can also present with abdominal pain, fruity breath because of the high ketone levels, and a type of breathing that is deep and labelled, named Kussmaul's. Patients with DKA start breathing like this because they want to limit the acidosis by offloading carbon dioxide. HHS can present with similar symptoms that we mentioned in DKA, however they will be poorly for a longer duration than patients with DKA. And because these patients have been suffering from polyuria, polydipsia for a long time, they'll be very dehydrated on presentation. They may have a reduced GCS on presentation and may have also developed some focal neurology. Let's move on to the management of both of these conditions. When thinking about the management of DKA and HHS, you need to remember 4 parameters: fluid, insulin, potassium, and glucose. The first thing you need to do in both of these conditions is to make sure that their dehydration isn't so severe that the systolic blood pressure is below 90. If so, you will need to give them resuscitation fluids, such as 500 milliliters of normal saline over 10 to 15 minutes, making sure that they have enough circulatory volume going around their body. Once the patient's blood pressure has been restored, you can give the patient with diabetic ketoacidosis IV insulin with IV fluids at a maintenance rate. Intravenous insulin should be at a rate of 0.1 units per kg per hour. What's more important in HHS is that you give the patient IV fluids at a maintenance rate so that the hyperglycemia can be diluted and their osmolarity levels can come down back to a normal level. The next factor that you need to consider is potassium. As you'll be giving insulin in diabetic ketoacidosis, there's a high risk of hypokalemia. So it's important that you establish a baseline for a patient's potassium before you start treatment. If the patient's potassium level is above 5.5, no further potassium needs to be given. However, if the potassium levels are between 3.5 to 5.5, you will need to add potassium chloride as an additive at 40 millimoles per litre. If the potassium levels are below 3.5, you will need to review this with a senior doctor. As you're pumping in intravenous insulin in diabetic ketoacidosis, there is a risk of hyperglycemia. So once the patient's blood glucose levels drop below 14, it's important that you start them on 10% glucose at a rate of 125 milliliters per hour to reduce the risk of hyperglycemia. In both conditions, it's important that you monitor the patient's blood glucose levels and ketone levels every hour so that you can make an adjustment to their insulin rate accordingly. That's all for this video on DKA versus HHS. I hope you enjoyed the video and learned something new. If you would like to read up more, please look at the links in the description box below. Please give a thumbs up if you've enjoyed this video and subscribe to the channel. Thanks for watching.